Hi, everyone. Thank you so much for attending our webinar. We'll be waiting for just a few moments longer to have more people sign on, so thanks so much for your patience. Hi, everyone. For those who just came on, this is just a quickly note that we'll be beginning shortly. Thanks. Okay, so I think we're ready to begin. Firstly, I'd just like to ensure that everyone can hear me. So if you can you please type yes in the chat box, which you'll find on the left-hand side of your screen. Perfect. Okay, I'm seeing lots of yeses. Thank you so much. Welcome to Asthma Canada's Severe Asthma Charter Series webinar on severe asthma and phenotypes. Our 2020 webinar series has been made possible through educational grants from AstraZeneca, Novartis, GSK, and Sanofi Genzyme. Today, we'll be speaking about severe asthma and phenotypes, and I know this is an incredibly important topic for Asthma Canada and our community, so thank you so much for joining us. My name is Kristen Belwa, and I'm the Manager of Communications, Programs, and Public Engagement at Asthma Canada, and I'll be moderating today. So before we begin, just a few quick points. The webinar is being recorded and will be uploaded to our website shortly, so please do feel free to share this within your networks once the recording is made public. All attendees are muted, but at any point if you have questions, comments, issues, etc., please type into the chat box, which I'll be monitoring throughout. There's also a little blue question mark at the top of your screen. You can also type your questions there. There will be a Q&A at the end, but please make sure to type any questions in as we move throughout the presentation so you don't forget. So very quickly, I'd just like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. At the heart of all we do is our vision to empower every child and adult with asthma in Canada to live an active and symptom-free life. We're committed to improving the lives of the Canadian asthma community through education and support services, advocacy, and research. Asthma Canada encourages self-management by helping our community take control of their symptoms. We do this through our educational resources and services like our asthma and allergy helpline and webinar series, just like this one. We're also committed to bringing your voice to the forefront of policy decisions that affect our community, advocating on important issues like sustainable clean air and energy, choice and access to treatments, and access to medications in schools. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. We have a national research program which supports graduate level students studying early or late onset asthma. And we actually just announced the 2020 winners last month. So please feel free to visit asthma.ca for more information. Much of the work we do is through our community of volunteers and members across the country. People living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all the work we do and who provide support and input into our initiatives. So I absolutely welcome you to join us if you haven't already. And now I am pleased to introduce our distinguished presenter, Dr. Jason Lee. Dr. Jason Lee is a medical doctor who is a fellow in clinical immunology and allergy at the Royal College of Physicians and Surgeons of Canada, fellow of the American Academy of Allergy, Asthma, and Immunology, and fellow of the American College of Allergy, Asthma, and Immunology. He's the past section head of asthma for the Canadian Society of Allergy and Clinical Immunology, 2013 to 2018, and current member of the Biologics and Therapeutics Committee at the American College of Allergy, Asthma, and Immunology. So thank you so much for being with us today, Dr. Lee. I'm especially delighted to welcome you back and that you have your video on. It is so nice to see a friendly face. So I'm happy to pass the presentation over to you.
Great, thank you. Yeah, I am the neighborhood-friendly allergist. I guess from the beginning of my career, I did focus on the severe end of the asthma spectrum from the very beginning. I can't seem to change the slide though. It's stuck on this slide. I don't see the controls anymore. Oh, here we go. Okay. So yeah, I'm here to talk to you about phenotypes of asthma. And as human beings, we have like a tendency to lump things into categories. It kind of helps us conceptualize things and understand a framework to view things in. Okay, here we go. So my disclosures, I think a lot of the sponsors who have supported, some speaking or research in the past are here. I see them on the attendee list. And thank you for attending and for everyone else as well. Really, the objectives today are I'm going to try to explain the molecular or immunologic basis of the different asthma phenotypes. I think, rather than looking at clinical presentation alone, this gives us an understanding of where this clinical outwardly manifestation comes from. So I'm an immunologist by training, both in my fellowship and my undergraduate. So this is kind of the lens and framework that I think about things. And I think this is kind of the lens and framework of how the research is going as well. So it kind of synergizes nicely. I'm going to look at different categorical ways of phenotyping. And really, again, it's, human beings are clumpers. We like to think about things in discrete categories. Really, the prevalent way of looking at and conceptualizing things now is type 2 versus non-type 2 inflammatory asthma. So we'll spend time looking at this. This is the overarching framework that most people use now. And then, of course, I love basic science, and I love explaining basic science to everyone. So we're going to look at about what the cells are, how they're turned on, that's the transcription factors, how they communicate to one another, those are the cytokines, and really looking at how understanding all this stuff kind of helps us decide, what is maybe the best medicine or best treatment for each particular patient. So immunology is blurry science. Nobody likes memorizing a phone book of pathways and messages, but I hope this becomes a little bit more clear at the end of the talk. So you'll hear about this a lot lately in the literature, type 2 inflammatory mechanisms. This is from, this is basically what I see as an allergist. I see from some food allergies, I see people with sinus problems, I see, of course, allergic nose, asthma, some COPD, and atopic dermatitis. At the beginning of my career, especially as a trainee and the first few years of my practice, I go to these international meetings, and people would swear up and down that there is no connection between, eczema and asthma, or vice versa, any of these. Now we kind of understand that all of these are the result of the same dysregulation of the immune system. So of course there's overlap and comorbidity, and the same cellular processes, give you different manifestations depending on which organ is affected. So this is becoming much more clear now, especially in the last 5 years or so. So I mentioned eczema, and a lot of patients with asthma, if you ask them, will note at least some degree of atopic dermatitis or eczema. And I think in Canada, a lot of respirologists, see a lot of asthma, and I don't think honestly that many people look at the skin or care about the skin, nor do they have training in the skin. As an allergist, we're kind of in this unique intersection where I do look at the patient much more holistically, and I do treat atopic dermatitis. It's a big part of my practice. I do treat a lot of asthma. It's a big part of my practice. So I notice this pattern occurring, and some people have atopic derm in infancy. It kind of goes away, and then they either go into complete remission for the rest of their life, or they continue to have it. Other people are later on in childhood, other people later on in teenagehood, other people have adult onset, and some people have very late onset. Particularly women who are postmenopausal and whatnot. Now, let me show you in a similar pattern here. If you look at different patterns of asthma, so some people get some kind of weird virus or it causes a transient wheezing, and the viral, it's kind of transient, but other people have persistent wheezing and along with other atopic comorbidities. Other people it kind of comes and goes. They develop seasonal. Other people get it as a teenager, or other people get it much later in life. And again, it's a lot of older women postmenopausal. So you see the similarities, and when you see it one slide after another, it's easy to see that there must be some kind of link between the two. So when we look at, this is an atopic dermatitis study, looking at, different types of comorbidities, and you do see that these things do kind of occur more than you would expect by chance alone. So allergic rhinitis, asthma, food allergies, nose or sinus problems, other autoimmune disorders, conjunctival disorders, and nasal polyps. So there's clearly some kind of shared thing that must be predisposing people to developing these comorbidities. So to understand and answer this question, we look at what is driving this process. We look at the immune system 560 million years ago. Okay, this is like a long time ago. The orbits of the planets were very different. The continents were very different. But in any event, we developed a part of our immune system to fight things coming in. So eosinophils, mast cells, these are part of the primitive defense mechanism of the body, and this got refined so we could respond faster to threats. So allergies in a nutshell is when your body deals with things in a coordinated way, and there's different types of inflammation. Okay, one is an attack inflammation, one is a repair inflammation, one is a different kind of neutralizing inflammation. So depending on which one gets turned on, you ideally want to select the right one for the right response. So what happens when this process is dysregulated or not working well? Well, you have a disruption of your barrier. This could be in the nose or the lungs. I'm showing the lungs here. This could even be the skin. You got things coming in. Your body has to deal with it. It activates a cell called a T cell, and it tries to figure out what it is. It responds to the SOS signals coming out of the epithelium. And we get the cell, if it thinks that there's some kind of parasitic thing, it goes into what's called a Th2. It's driven by this activation signal called GATA3. And what this does, it makes a bunch of chemical signals to communicate to other cells, and you produce allergy antibodies. This goes on to different cells. The main one is the mast cell. It also goes onto this cell called eosinophil, and you got this IL-5 chemical signal. It's a cytokine that brings more eosinophils out of the blood and into the tissue. You get IL-13, that increases the number of goblet cells that produce mucus, and you get more smooth muscle cells, which cause more twitchiness. This used to be called the allergic eosinophilic airway inflammation. Now you got cigarettes, smoke. We had industrialization occur about 100 years ago. A lot more atmospheric particulate matters we're inhaling. This sends SOS signals again, and it activates different cells. Now we discovered the cell in the mid-2000s called innate lymphoid cell type 2. It also has that activation signal, that on sign called GATA3. So that has the ability to make the same chemical signals, IL-5, recruiting eosinophils, and IL-13, more goblet cells and smooth muscle. We call this non-allergic eosinophilic airway inflammation. So this is an older categorization of the different phenotypes. So you could say it's non-allergic or allergic. You could say eosinophilic or not, and there's non-eosinophilic as well. So this is one way of phenotyping or categorizing asthma. I mentioned the mast cell. It activates through many receptors, but one of them is the allergy receptor. Okay, it's the antibody that acts as a receptor. Let me talk to you about GATA3. This is the what's called a transcription factor. A transcription factor is something that goes and activates a bunch of different genes and signals. So GATA3 activates through many ways, but one of them is the IL-4 receptor. It can be activated by IL-13 as well. It goes and you have a bunch of signaling things happening in the cell, and these things go into this protein complex, essentially goes into the nucleus and activates certain numbers of genes. And here we have GATA3, I'm showing, which activates the signals 4, 5, and 13. So these are the signals that activate something called type 2 inflammation. Th2 has this, and ILC2 has this. We got other pathways too, which I won't get into. Now, determining, we don't really quite understand this in human beings. We're starting to figure it out in mice. But certain GATA3, certain people get a little bit of more IL-5, certain people get a little bit more IL-4, some people get a little bit of IL-13. We don't quite understand what determines this level of activation. Is it, epigenetics, the change in the activation? Or what is it? We don't know. But some people get more skewing of one over the other. And one thing I want to point out is, there's ILC1 and that secretes interferon gamma. That's more in COPD. So if you're a smoker and you have more ILC1, you get more something like that looks like COPD. You get more ILC2, you get something more like asthma with reversible airway inflammation. So I love this slide because it explains the different cell players involved and how it's not just about one cell over another. All of these cells work in concert together. It's like a master orchestra. You got the Th2 cell that can produce the type 2 inflammatory signals, ILC2, but any of the what we call effector cells, the end cells that cause the damage or cause the inflammation, can also activate this process as well. So eosinophils, mast cells, and basophils, they all have this GATA3 transcription factor. So Sally Wenzel, came up with this brilliant diagram, great researcher from the U.S. in 2012, where she classified things as type 2 or non-type 2. So type 2 is really driven by those three cytokines, 4, 5, and 13, and you can classify this as, type 2 inflammation. The non-type 2 are some of the more lifestyle things. You got obesity-associated phenotype. Okay, if you're obese, you produce more, certain types of lipid inflammatory mediators because you got a lot more lipids or fats. You got a lot more fats. It promotes more lipoxygenase pathway activation. You got late onset, the postmenopausal woman thing I mentioned. You got smoking associated and neutrophilic, and you got people with smooth muscle issues. So this is the non-type 2 inflammatory asthmas. You got the type 2, and again, if you remember, 4 makes IgE, allergy antibodies, so that's the allergic asthma. You got IL-5, too much IL-5, you got the eosinophilic asthma. You got exercise-induced asthma, you got aspirin, exacerbated respiratory disease, and all of these kind of are not, independent. There's a lot of overlap and considerable overlap between the two. There's no one pure phenotype within the type 2 inflammatory types of asthma. So we do have this evolution and natural evolution in terminology, we're discovering so much more about the basic science and underlying mechanisms. So we all know what asthma is, heterogeneous. I think even the ancient Egyptians had some documentation of asthma. It's chronic airway inflammation. Most of it is reversible, especially in the beginning. You got Th2, which refers to a helper T cell population. It's part of the adaptive or the second line defenders of the immune system. This is all we knew in the 90s. and this terminology has stuck to clinicians to this day. But really, what they should be thinking at is incorporating the new science, the innate lymphoid cell 2. This is type 2 inflammation. You acknowledge that there's an adaptive side, Th2, but also an ILC2, an innate side that contributes to this and can produce those same inflammatory cytokines. So we call type 2 asthma when it's driven by both either or and or, I should say, the innate and adaptive immunity. Now, type 2 inflammation is actually the same fundamental dysregulation in atopic dermatitis, eczema, chronic rhinosinusitis with or without polyps. I put with polyps. That's more concretely proven. Allergic rhinitis and conjunctivitis. Eosinophilic esophagitis, which is a problem in the esophagus. It essentially is esophagus asthma. And I argued chronic urticaria and the condition called prurigo nodularis. There's also this IgG4 related disease, which is what happens when you have this dysregulation throughout your entire body. So these are this is a slide out of the Global Asthma Guidelines called GINA, Global Initiative for Asthma. And when we look at this, they talk about the three main categories of biologic medication used to treat severe asthma. And when you read this in detail, and when you pull up the original studies that they based these recommendations on, you'll see that the markers, or how doctors decide, called biomarkers, all point to good data or better data for all three drugs that overlaps. So all of them respond better the higher the eosinophil numbers you have, and all of them respond better if you have more inflammation. And this is all because they all exist in this type 2 inflammatory space. So all the biologic medications we currently have are in this type 2 space. We have a lot more things coming up in the future with things called JAK kinase inhibitors and other things that can more globally affect the immune system. But I think there's quite a few things that are in the future. We've got neutrophilic. We don't have any good treatments for it right now, other than antibiotics, and it seldom works. And we've got obesity, which I mentioned before. So cells see allergens as pathogens, and here's some beautiful data on omalizumab, which a lot of people think is only treats allergic asthma, quote unquote. You see the receptor of the eosinophil, which is one way the cell gets turned on in quote unquote eosinophilic asthma. And you'll see some of their studies show that, the higher level of eosinophil means that omalizumab also works better. It's because the receptors on these eosinophils go down when you block the allergy antibody, because that's the receptor. And this has a nice dose dependent effect. We also see that the ability of the receptor to bind actually goes down as well when a patient's on omalizumab. So again, I just want to highlight that everything plays into together. So you can't say there's one cellular phenotype because they're all interconnected. When you have a lot of eosinophils and they activate, they actually have quite a bit of cytokines that are produced and they all activate the other cells. So again, it's simplistic to think of it as one pure cellular phenotype. And again, this is the data from omalizumab, which treats only allergies. That's what people think. But you see that it actually also affects IL-13 levels. So this cytokine is produced from mast cells. So if you block the mast cell activation, you get less of the type 2 inflammatory cytokines. And this is part of how it works. So it's not as simple as blocking allergies. So majority of asthma is driven by type 2 inflammation. Luckily, most severe asthma, 50 to 70%, is this type 2 inflammation. And when we look at the blood here, okay, all of these cells come from your bone marrow. They're from, myeloid progenitor cells, and they differentiate into mast cells, basophils, eosinophils. They all have to get out to the tissue. They operate like any other cell based on cell depolarization, repolarization, intracellular cascade, phosphorylation. If you remember the glory days of your first year university chemistry, and they all have genes that activate. And we don't quite understand this process. We do know that certain signals attract them out of the blood and into the inflammatory cascade. It's kind of like the the military calling for the artillery backup. And we do know that some of these signals like VCAM and ICAM1, these are little signals that allow the white cells to get out of the blood. We know that these are important. We also know that all these chemical signals, 4, 5, and 13, are capable of inducing these changes. So again, not to harp too much on the atopic dermatitis issue, if you have atopic dermatitis, you're more at risk for infection because you have an aberrant or a dysregulated immune response. We know that asthmatics, in addition to having, if you have asthma and atopic dermatitis, you're much more likely to get infections. So we know this about patients with asthma and eczema. At those sites, you get more infections. And this is because of a dysregulated immune system. So when we look at the skin, and I could just rub this out and write lungs or any other tissue, we have a dysregulated process of type 2 inflammation, which causes a lot of asthma. And this is I would say, a overarching phenotype. These all secrete chemical signals. They immortalize each other, and they immortalize temporarily to fight infections. The problem occurs when this is overly turned on and permanently turned on. You have an inability to deal with other infections and have an inappropriate immune response where you're drawing more and more of these cells out to the blood, and this results in chronic changes long term. So type 2 inflammation is the pathophysiology of every disease that I treat, and we are learning more and more about this. And this is nasal polyps, which is another type 2 problem, which a lot of patients with asthma have as well. So these comorbidities, and paying attention to every system comorbidities, is pretty important. When you really drill down to it, they all share the same pathway of dysregulation. And this is a beautiful MRI picture study that I saw of a severe asthmatic, who was not doing so well on biologics, but did pretty well on the latest one called dupilumab, which really was able to inflate all parts of the lung. And we see here that the patients with epithelial dysfunction, epithelium just means the barrier. This can be in the skin, lungs, anywhere where there's an interface between you and the outside world. Okay, and I mentioned the IgG4 related disease. This is really cool. This is a patient that we was kind enough to allow us to share images and publish. If you look here, this is an MRI image. This is just an example. If you look at his skin, he looks like he has very bad atopic dermatitis. He has very bad asthma, but it's not just limited to those organs. He's got it everywhere: pancreas, retroperitoneum, kidneys. So when we shut off the main cytokines, we can see that we've actually reversed him, and all of his organs are normal again. So normally this condition leads to pretty much certain death within 5 years. The 5-year survival is quite abysmal, but we're able to make a difference in him by re-regulating him back to normal. And so hopefully this picture is from blurry to clear, and thank you for your attention.
Perfect. Thank you so much, Dr. Lee. So we do have a couple questions that came out of the chat box. But again, this is the time to ask, so please don't be shy. Just type them in and we'll be sure to get to them. Okay, so our first one comes from Bruce, who asks, can your phenotype change as you age?
The question was, can your phenotype change? Absolutely, it can change. So there's a few studies looking at sputum values of severe asthmatics. And sorry, I just turned off my video by accident there. Oh, webcam. Oh, I can't turn it on. Okay. So there's a few studies looking at the same patient, even from year to year, can change. They can go from a eosinophil predominant in their sputum to a neutrophil predominant when they have an infection. And it's usually moving from one type 2 to another, though. And of course, one patient can have more than one. They could have, be both obese and have type 2, or they can be a smoker and have type 2 as well. So there's many, differences and changes that can occur within a lifetime in the same person.
Perfect. Okay, thank you for that. Our next question comes from Zach, who would like to know how do you know or how do you find out what phenotype that you have?
Yes, so the phenotype really depends on biomarkers. And right now, the biomarkers are frankly pretty poor. We have enough biomarkers to tell you if you have type 2 or non-type 2, but in terms of the readily accessible and commercially available ones for the non-type 2, it's very hard. Sometimes it's obvious though, like you can look at a body habitus and weight and height of a patient, figure out their BMI, or the patient actively smokes, or that there's a strong family tendency of allergies starting at a very early age. But other times within the type 2, it is very hard because there's also overlap as well.
Perfect, thank you. Our next question comes from Carmela, who asks, would patients with high IgE levels but low or normal eosinophil levels respond to other biologic drugs aside from Xolair?
Absolutely. And there's very good evidence that drugs like that only treat IL-5, for example, mepolizumab and Benra. They both have studies showing that it also treats the allergic symptoms as well as the allergic phenotype. And similarly, the dupilumab has very good data showing that the more allergy you have, the better the drug works as well. So again, it's not this fixed little concrete, discrete entities. There's a considerable overlap, and they all exist in the type 2 inflammatory space.
Perfect. Okay, sorry, I'm just getting to another quick question here. Um, let's see. Oh, Anita asks, are certain asthma phenotypes linked to different comorbidities other than atopic dermatitis?
Absolutely. So there's ones that are more linked with chronic rhinosinusitis. So you got chronic sinus problems and asthma. Others are linked to other extra pulmonary manifestations like eosinophilic esophagitis. Others are more linked to, there's not that much evidence in it, but I think urticaria is another one of them. Again, I went to so many meetings where everyone insisted there's no connection, but there is actually a clear connection in some patients. And there's other ones that are associated with autoimmunity. So there are many different comorbid conditions that are linked to this. It's really we don't quite understand exactly what links some and not others in some patients. And again, this probably relates to differential activation of different parts of the immune system. We're just figuring it out in mice and simple organisms, but I think it'll be, another 5, 10 years we'll begin to start really understanding this.
Perfect. So this next question comes from Kim, who says little attention in the asthma community seems to be focused on food allergies unless they show up in testing. Yet I clearly react to dairy, eggs, and soy in spite of not testing allergic to them. Your comments, please. I had asthma as a child, many years symptom free. Now am moderate asthma leading to severe soon, I fear.
So what I can say is we spend a lot of time in medicine, like subspecializing, and it may not be the optimal approach to do medical training, honestly, because you don't get a breadth of knowledge in every discipline, and it's impossible, quite frankly. Some patients do worse with certain foods, and there's a whole book written about this, and they made a lot of money. I wish I'd written it, but there are drug properties of certain foods. So wheat, dairy, and dairy proteins and wheat proteins and egg proteins, for example, have weak narcotic or mu opioid effects. So these can actually aggravate patients in terms of respiratory symptoms. Other foods that have food preservatives, which is kind of not really well known, and a lot of people, sulfites is a common food preservative that can trigger asthma in some people as well. This usually means that your asthma is not very well controlled if you're reacting to these little food triggers, and it's maybe a time to look at stepping up on the asthma treatment algorithm.
Perfect. And we have another question. Would patients with T2 inflammation benefit from genetic testing? Would it shed more light on their medical condition?
Yeah, so this is really interesting. I've had a few of my patients pay out of pocket for genetic testing, and it actually was very helpful in terms of selecting the right biologic. I had one guy, the first guy who brought me his results, showed that he has a interleukin 5 receptor mutation, and he's doing really well on IL-5 receptor blocking therapy now. So yes, it's just it's beyond the reach of most people's financial means, unfortunately, but it is very helpful, I find, if that information is available.
Oh, sorry about that. Okay, sorry. The next one's just coming in here, and this question is from Danielle, who asked, does your phenotype affect your treatment if you have moderate asthma?
Sorry, if you could just repeat, I just missed that question.
Oh, for sure. Does your phenotype affect your treatment if you have moderate asthma?
Um, it doesn't really, because inhaled corticosteroids are pretty good, like at treating all phenotypes of asthma. So you got pleiotropic effects, and this is the thing about steroids; it hits every single cell, right? And that's why oral steroids or systemic steroids lead to so many problems and side effects. But because it treats every cell, it does a pretty reasonable job, especially if you combine it with LAMA or long-acting beta blocker, or sorry, beta agonist, I should say, or a llama, which can kind of work on all cell lines.
Okay, thank you so much for that. I have here, let's see. Perfect. Okay. I think if that is the end of the questions, we will probably end here.
Okay, great. Yeah, sorry, it went a lot faster than I, I thought. There was a lot
No,
of slides.
that's
Thank you
okay.
for your
That's
time.
okay.
Yeah.
I'll give everyone just like a quick minute. Oh, Carmela asks again, just to follow up on that last question, how much does genetic testing cost?
It depends on the type of genetic testing you do. So, a couple of my patients have done the entire genomic sequencing. There are companies that actually offer just an asthma profile, actually, that tells you about the polymorphisms of the relevant genes. And I was actually quite impressed how much these companies knew about what genes and transcription factors, for example, are important. So, they knew which cytokine genes were important, they knew what transcriptions, and they produce a pretty meaningful and beautiful result if you actually read them. I'm reading the next
Interesting.
question from Deborah. I have colitis. Is it
Perfect.
related?
Thank you. Yeah.
Yeah. And it may very well be. In some patients, that we have a different T cell called a Treg cell. A dysregulation in Treg cell causes both asthma and IBD as well. So yes, these are definitely related in a lot of patients.
Excellent. And another question from Kim. Thank you so much. Keep them coming. What criteria do you feel need to be met in order for a patient with allergic asthma to qualify for biologic therapy?
It depends, like what the medical criteria is and what the insurance criteria is, unfortunately, right? So, insurance criteria and government criteria, I do not keep a pace with the medical science. And, I love how Asthma Canada advocates for things like this. We need to update these criteria for the insurance and coverage criteria like every year, but it's just not done. It seems to be fixed in stone in some cases, which is unfortunate.
Wonderful. Well, thank you again so much, Dr. Lee. Really appreciate you taking the time to be with us today, um, and taking the time to answer questions from our community.
Thank you very
Um,
much for the opportunity.
yeah, and thank you to everyone for attending. Um, we we love to have you. If you've benefited from our webinar series and you'd like to see similar programming, um, please consider making a donation at asthma.ca. And if we didn't get to your question, don't hesitate to, or something comes up later, don't hesitate to email us at info@osmond.ca. Um, we would love to hear from you. All right, thank you so much. We really appreciate you being with us today.